My name is Tarek Sharaawy. I am the head of glaucoma in the University of Geneva, Switzerland. It's a pleasure to be here in Italy. I was asked today to give a summary of what is new in glaucoma surgery. I spoke specifically about subconjunctival filtration, new devices like the Zen implant and the microshunt implant, whether from an ab internal or ab external approach, what that would bring to our practice. The fact that those devices are associated with a morphology of blebs that are very different from what we're used to. We're used to blebs on the limbal side of the eye that are usually high and sometimes are cystic and sometimes are thin and sweating. And then we know blebs around filtration, around valves, around an Ahmed or a Barvel. Those new devices like the Zen and the microshunt are somewhere in between the two blebs, and in between in terms of shape and also in terms of distance from the limbus. So they are 6 to 8 millimeters from the limbus. They're usually shallow and diffuse, and they are not as thin as we see after blebs with mitomycin that we have produced in a trabeculectomy or a deep sclerectomy. I also spoke about suprachoroidal implants, something that is very interesting. It is blebless, because we will be able, hopefully, to reduce pressure without relying on a bleb. So those devices are inserted into the suprachoroidal space. The two leading contenders are the SciPass and the iStent Supra. They both are placed in the same area, basically creating a space between the choroid and the sclera. They're interesting because they're not really that difficult to implant as you would imagine. The rigidity of the sclera is very different from the rigidity of the choroid, so implanting those devices is not a big challenge. And the fact that we are not having a bleb, the fact that we can combine them with a phacoemulsification makes them a really interesting option. Now, will they be able to produce good pressure reductions to prevent reoperations or to prevent deterioration of glaucoma remains to be seen. There are some positive data coming out from all those devices, and to be honest, we probably think of the pressure reduction as a pressure that needs to be significantly low, and that is because we are always having in our mind advanced cases. But in fact, a lot of cases, if we operate them early enough, we would not need very low pressures. And to be direct and blunt, if I personally have to have an operation and I would choose between a very low pressure of 8 or 9 with potentially visually decompensating complications, or an operation that would give me a pressure of 13 or 14 with a safer margin, I personally would opt for a safer margin. So safety becomes more and more an outcome that is extremely valued, and probably will be more valued with time, because our patients they know intraocular pressure, they think of intraocular pressure, but what really matters to their eyes and to their lives and to their quality of lives would be their ability to maintain good vision for the rest of their life. So I thank you very much for the nice interview and for inviting me to your beautiful country.